Good evening, ladies and gentlemen, and welcome to Perspective Nation. Today, we shall be talking about the nurses' experience in the intensive care unit and the emergency room due to changes in COVID-19. Please, this podcast is for educational purposes only. We, however, encourage everybody listening or watching to use this opportunity to start a conversation about the impact of COVID-19 with family and friends. We have been having a lot of mixed information, and a lot of data has come out due to COVID-19, but it's not been very clear which data we can rely on. So today we are bringing in somebody who is experienced or who has seen the changes as they appear and in the most critical cases, and she's going to be talking about some of those cases. Thank you, Birgit. We are so happy to have you here. Please, can you kindly tell us about yourself, who you are, where you work, what is your specialty, what are some of the common things that you've come across in your part of work, and what else do you think we should know about you?
Thank you so much for having me on this platform. I appreciate the opportunity to be able to share some truths. So my name is Birgit Umaigba. I'm a registered nurse specialized in critical care nursing as well as emergency room nursing. I'm also a clinical instructor, and I teach in the nursing program at Centennial College and also at York University. I teach internationally educated nurses, nursing students in their Bachelor of Sciences program, and also registered practical nurses bridging to become registered nurses in Ontario, pretty much. I'm also a mom, and I'm a wife, and I'm a sister, an aunt. A few months ago, I did, lose my voice a little bit, so permit me to take sips of water while I talk. Prior to that, I actually sang. So music is my other passion, and I did do a demo. I thought that was my, career path at some point. So yeah, this is me now. I'm a mentor. I mentor internationally educated nurses through some colleges in Ontario, guiding them through their navigating the very confusing, licensing program in Ontario, as well as I also speak at various universities as a guest speaker, and also precisely as an advocate for anti-racism in healthcare and in general. So that's a little bit about me. I work at different hospitals across Ontario. So far, I've worked at about 26 different ICUs and emergency rooms. So I think I have a picture of what, the inside of hospitals do look like, especially during the pandemic and importantly, prior to the pandemic. So here I am. I'm very vocal about equitable healthcare in Ontario because I do see the effects of inequitable policies on the people that have been made marginalized in our society. And I do think that every aspect of our lives is political because we're affected by policies one way or the other. So thank you for this platform.
Thank you so much. And let me extend our appreciation to your family for allowing you to join us this time. I think this should be the time they should be enjoying with you. I somehow did not get the part I was hearing. Let's talk about your Twitter activity. You have almost 44,000 followers on Twitter. Tell us a bit more about your Twitter journey.
So actually my Twitter, I think I've been on Twitter for, I don't know, probably like a couple of years, 7 years or 6. I don't recall when I joined, but I started using it early last year. So precisely the month of February, I was advocating for family reunification because at that time I was trying to get my husband here in Canada, and having gone through the discriminatory immigration system and the challenges navigating through it, I found a group on Facebook, and this group was advocating for families to be reunited in Canada. So I happened to join them on Twitter, and we started storming Twitter like every Tuesdays, calling on the Minister of Immigration and all of that. And somehow, with that, being a nurse, I pivoted into nursing. I'm like, okay, this is a good platform to talk about the issues that are affecting nurses as well. So that's actually how I started tweeting about family reunification as well as nursing. And then, the conversations grow, and people are actually drawn to truths and, stories. And somehow I connected with a wide range of people, and it's been an amazing journey. I've learned a lot. Through Twitter, I've learned several aspects of Canadian politics, as well as advocacy in different groups, and learning language and learning what not to say, and so socially accepted behaviors and all that. So Twitter is a huge platform that has its pros and cons, and I would say it's allowed me to connect with wonderful advocates and people who are just there to to speak up about inequities and the effects of social determinants of health on people's lives. And I've been able to connect with colleagues, physicians, scientists, researchers, and through that, and also call on the media. I've been able to advocate for some good causes, especially internationally educated nurses, calling on the media to start profiling them, to hear their stories of how they are so discriminated against when it comes to transition into the workforce. And here we are having a massive shortage of nurses. And I have a lot of internationally educated nurses as students who work at Walmarts, they drive Uber, just to be able to survive. And these were nurses back home. So I think we were able to get the attention of the Minister of Health sometime last year. And they did work with the College of Nurses to create a faster pathway for INs, so internationally educated nurses. And so that's slowly coming to fruition, and some small wins. But that being said, Twitter has its own disadvantages too. Like, there's a lot of hate. People feel very free to say whatever because they're behind their screens and they feel just behind their keyboards, they can say anything. And we know that racialized women are more targeted. So yes, that's basically my journey on Twitter.
Well, one of your colleagues, I don't think, she works in the healthcare industry, and she's been following you now for she said close to 2 years. She believes you are the most influential nurse in Ontario. Do you have anybody told you that, or do you feel that way, that you are influencing more policy? Like she was saying, she believes you have influenced more policy in the last 2 years rather than the College of Ontario. Is it College of Ontario Nurses?
Oh, okay. The College of Nurses of Ontario.
Yeah, something like that.
Yes, it is.
Do you feel that
College of Nurses in Ontario? Honestly, I feel so honored by that, but I do not feel that way. I just feel like bringing the stories and talking about the things that people prefer not to say, especially the privileged people in our society. And I honestly find it such a privilege to be able to speak about the challenges that nurses, personal support workers, patients face, given the fact that a lot of people are either scared to talk because of fear of reprisal. Some people would definitely lose their jobs if they speak up. I know colleagues who are PSWs who were made to sign waivers not to ever speak about their working conditions. And that is why we saw a lot of older adults die in nursing homes, because these people were not allowed to comment or even speak to the media. So I feel privileged that way because I'm also not hired by any specific hospital. So I can speak about these conditions without my employer calling me into their office to say, okay, Birgit, you have to stop. I know that some colleagues have been called into the office for advocating for patients and nurses. I don't like to compare myself with anybody. I just believe I'm on my journey, and I have been able to speak with some politicians. I remember sometime last year, Jagmeet Singh requested to speak with me, and I did meet with him and told him the challenges of nurses. I also met with Andrea Howard. I told her about what nurses were facing. Some members of the Liberal Party also spoke with me. And yeah, some of my tweets were read in the parliament. Some of the MPPs actually read my tweets in Parliament, and I felt, honored by that the word is actually going out and going to those tables where they need to be heard. And in all of this, not one member of the Conservative Party has asked for an audience or to hear from actual nurses working on the front line, which is very problematic given the fact that nurses are quitting in drove because of a wage suppression legislation that was implemented by a conservative government, precisely Doug Ford in 2018 when he got into office. And to think that that same government doesn't deem it necessary to speak with any nurse, given the fact that nurses are right all over the media right now because of the crisis. So I find that very disrespectful. So yes, I feel honored to be able to influence policy in that little way and speak about the issues at hand.
Okay, let's talk about Doug Ford. You had a tweet that was threatening, well, that was trending, I think last year. You invited Doug Ford to come and spend, was it a day or a week with you at the hospital? And what happened about that?
It's been very tough working during the pandemic. I've had moments where I honestly wanted to quit nursing. But I do love what I do, and I'm not one that tends to give up easily. The thoughts do come, but it's really hard to quit. And I remember that one shift where we were so stressed. I think over 6 hours of no bathroom break, no snack break, running around. We were so short-staffed. So imagine a unit that is normally run by, say, 22 nurses, and we had 11 nurses. So 11 of us doing the work of 22 people, no pay, no incentive. So you wonder, so we're actually taking the burden without an incentive. And some of my colleagues actually ended that shift in tears at the nursing station. It was like morning center, a graveyard where people are just bawling their eyes. The moral, the stress of not being able to provide the quality of care that you want to provide for your patient. And it was just hard. And then you turn on the news, you hear about beds being added to hospitals, new construction sites being erected. And I'm like, Doug Ford needs to come and work with me at the bedside for a 4 hour shift, not even 12 hours, just 4 hours, just to see, to see what we go through and to see what patients go through. And I was just, very stressed and distraught. And I sent out that tweet to invite him to come over and see for himself. I don't think he has stepped his feet in an ICU or an emergency room since this pandemic. And if he has, that's even worse, because at least we should see a change. At least there should be a repeal of Bill 124. So yeah, just the working conditions triggered that tweet.
Okay, just so you know, a lot of some of us really do follow your tweet, and they have a huge impact. And or just use this opportunity. I think I read one of your tweets today about a mom who was complaining that the son was playing soccer, and they called the only black kid a monkey or something. I am not sure how far-reaching you want your tweets to go. I am also a ref. I am a licensed referee for the Ontario Soccer Association, and we've discussed issues like that. And I will be taking that as well. I would after this, I would like to talk to you to know which match that was going on, so we can do some things about that. And I want to appreciate you for putting that out there. I will as well report it to some other quarters. So thank you. Thank you very much for what you do on your Twitter feed. We really do appreciate it. And for those of you listening and those who will be watching, I would really appreciate if you guys can go and follow Birgit on her Twitter. It's what's the handle again? Birgit Omo? Birgit Omo.
Yeah, it's at Birgit Omo. Birgit Omo.
Yeah, or if you put her name on the Twitter there as for research, you definitely see what she is doing. So let's talk more about ICU. How did you find yourself to become an ICU nurse? There are other parts in the hospital which are easy. You decided to go through the hard way. Let's start from the beginning. How did you? What is the process? If somebody is listening who wants to follow your footsteps, what would be the process to get that person to become an ICU nurse?
Okay, yeah, it's interesting. Somehow I never knew I wanted to be an ICU nurse. I just knew that I wanted to do something that is so detail oriented and knowing every nitty gritty about the patient, the science of it, all of that. And so, yeah, so first you do your nursing program, which is about 4 years. So I did mine at Seneca York University. So that I did the accelerated program, which was about 3 years and 4 months. And while I finished that, just while I was writing my NCLEX, which is the national exam, the board exam, I had applied for my master's degree. So I got into that. And so while finishing my master's, I applied to become a critical care nurse. So once you have your registered nursing license, so after 4 years of school, you can start working, or you could actually apply right away, because right now there are a lot of opportunities to become an ICU nurse. So you apply to whatever hospital you work at. They do have government funded ICU training. They're funded by partly by the hospital and by the government, because as we know that we don't have enough critical care nurses. There's actually no incentive to work as a critical care nurse. And that is why we are always short staffed. So critical care nursing, NICU, so neonatal intensive care unit, emergency room nursing, labor and delivery, OR nurses, these are all specialty areas. And these types of nursing do require additional schooling. So in addition to your 4 years in the university or college, you actually take extra courses to be able to practice in these specialty areas. So when I finished, I worked a little bit on the floor. So I was a float pool nurse. I worked everywhere across within the hospital, every unit except the specialty areas. And then I went back to school and to study for my critical care certificate. So when you can either be sponsored by the hospital, where you have clinical hours and in-class hours, and it's more accelerated that way. I think it was about 4 months, and you get your certificate once you pass the theoretical component as well as the clinical component, and you become an ICU nurse typically. Otherwise, if you don't want to go through the path of being hired or sponsored by the hospital, because there's a catch, you have to commit to, I think, 2 years of working in that specific facility. Otherwise, you have to pay back the money. So some people don't like that. They don't want that kind of commitment or clause, and they take the course themselves. A lot of colleges offer the critical care certificate course, and it's usually 8 months. And then when you pass, you become an ICU nurse. So you get hired by a hospital right away because there's always jobs. And then you start practicing as an ICU nurse. And in order to maintain your license and all that, you have to do certain courses. So prior to actually doing the critical care certificate, you have to have like your coronary care certificate and all of that. And there's also something called the Advanced Cardiac Life Support Program, which you have to be recertified for every 2 years, as well as your CPR. So there are a lot of courses involved in being an ICU or an ER nurse or an OR nurse or all of those specialty areas. But in all, it's really rewarding because I get to see the full picture of a patient in terms of I understand why they're there and all the various aspects of the disease process, because you do have to learn about those, and you work with every member of the interdisciplinary team, which is, is quite different from other types of nursing. Like when I worked as an ER nurse, people come in, whatever you treat, and you send them wherever. But critical care has allowed me to understand the full picture. So 4 years of school, in the nursing program, and then additional 4 months or 8 months of critical care course.
Okay, thank you so much. Let's go into the COVID-19. So give us a picture, give us an understanding of how the ICU or the emergency room used to operate before COVID, and what were the changes you saw at the peak of COVID. Let's start with before COVID. What were the expectations?
Well, prior to COVID, there was a shortage of nurses, okay? There's always been a shortage of nurses because I work as an agency nurse. I'm not hired by a hospital. So what I do is I am called by any facility where there's need, and then I go fill in the need, and I go. But prior to COVID, there was days where I couldn't get work because there wasn't that much need. They didn't need my service. Or sometimes I would go to work and they'll send me home because they were overstaffed. And in terms of, COVID changed a lot of things. We already had a shortage of nurses because Ontario has always had the lowest RON, so registered nurse to population ratio in all of Canada. Ontario has the lowest prior to COVID. And with COVID, you can imagine all of this shortages were further heightened by the pandemic because nurses are getting sick, people were quitting, and a lot of people are getting sick and coming into the hospital. People have COVID, people are scared of COVID, they don't want to come to work, like a lot of it. So prior to COVID, typically we'll have staff irrespective of the shortage, because we didn't have to deal with a virus that was making people sick, as so many people sick at once. So the shortage wasn't really that as felt as it is right now. So I remember going to work and, sometimes we're short 1, 2, 3 nurses and you manage, right? But since COVID, things have gotten worse. We're short 10, 15 nurses. The other day, an emergency, so we actually do have emergency rooms that have certain areas closed because there's no staff. So imagine, and you've seen, I'm sure you've heard on the news that certain ERs have been closed for weeks. People are told to go somewhere else. Surgeries have been canceled, delayed, and these do have implications. We've seen complications from delayed surgeries, right? Imagine if you needed your surgery when things weren't that bad, and now whatever the condition is has gotten worse. Patients are operated on, and they eventually ending up in ICU because your situations are worse. And we don't have the staff to manage all of that. I remember a week ago, a specific ER department that was supposed to have at least 30 nurses only had 8 nurses. I can tell you It takes at least 6 nurses to run a code blue if a patient has a cardiac arrest. What that means is if anything happens, is either someone having a stroke has to bypass that ER to go somewhere else, meaning that if they had time to be saved, that time may no longer be there. When someone's having a stroke, we have a 4-hour window to give a certain medication for it to be effective. But if you have to travel past your local hospital, way down to another hospital, you lose that, and there's a potential for death. So yes, the situation is there. Nurses are quitting. I've lost so many of my colleagues that have been in the profession for like 20 years. They're not easy to replace because, like I said, it takes years to have a nurse who can run the code, a nurse who can triage a patient when you get to ER, when you go to the emergency room department. It is not a brand new nurse that's going to triage you. It's a nurse that has experience, knowledge. So those are the nurses that are leaving, and it takes years to train those types of nurses. So COVID has actually laid bare the challenges we already had and actually heightened them even more. And the nursing profession right now is in crisis.
Okay, let's take a step back. You talk a lot about the shortage. Do we have an idea in terms of numbers what the shortage was in Ontario? And
I've actually tried to look for those numbers through the Canadian Nurses Association website. I didn't see anything comparing what the shortage was before to now. But I do know that there is a report on their website that actually says Ontario is, because they look at Canada-wide, but Ontario is short over, I think, 22,000 nurses and counting, right? Unfortunately.
Was that prior to COVID or during COVID?
During COVID, no.
Okay.
Yeah. Prior to COVID, we already but I can find the numbers to compare.
No, I just wanted those listening and those who will be watching to have an idea of how bad the situation is, because sometimes
it is very scary. You don't
sometimes we say shortage, and I'm like, oh, okay, there are 2 nurses short in this hospital, so that's not that bad. But
no, so we had, I recall a few months ago, we had a unit with a cardiology unit, only 1 nurse showed up.
Yes,
and we've also had, yes.
Yeah, somebody actually told me, like, as I said, when I posted this, I was surprised at the amount of people who reached out, especially those in the healthcare. Somebody actually told me at the heart of COVID about they had like an outbreak where she was working and all the nurses couldn't come to work and she was left alone with 34 patients. And she was like, you know what, I'm just going to do whatever I have to do. And if somebody has to die, somebody has to die. There's just nothing you can do. Did you ever face such a situation?
You know what? We face such situations. Well, in ICU, critical care, you can't have 1 nurse show up. People will die. Luckily, we've always had at least 10 nurses, depending on how big the ICU is. But even that is a recipe for disaster because you can only do so much. And these people need to be monitored one-on-one, compared to where that person works, which I think may be a nursing home. Those patients were stable, they were predictable in a way. An ICU department is not the same, right? Like you cannot have 1 nurse run an ICU. That would be like, we'll need the Prime Minister of Canada to be there in that very moment.
Okay, so give us a scenario, worst case scenario that you actually experienced in one of the hospitals in your ICU or.
Yeah, the worst was I was working in one of these ICUs and we had, I think is the same one where we had 22 patients. They were critically ill. I think a lot of these patients, more than 18, were supposed to have 1 nurse. As a matter of fact, sometimes the patient is so sick that he or she requires 2 nurses to look after them, depending on how sick they are. And that particular shift, every single person had 2 patients. I'm telling you, it was unsafe, completely unsafe to have 2 patients, but everybody had 2 patients. There was, and a lot of those nurses were new nurses with less than 1 year ICU experience. Never. When I started ICU nursing, that I never nursed under those conditions where I would have 2 very sick patients as a brand new ICU nurse, because there's so much you need to learn. You need to rely on the more senior nurses to guide you. Otherwise, you will make mistake and someone may die. Unfortunately, we have these brand new nurses handling 2 patients. It was scary because if you had to go for break, that nurse or you would have to have 4 critically ill patients that were, people don't understand. When in the ICU, a patient is on a life support machine on multiple drips, sometimes up to over 10 drips, has all the tubings, all the lines you can think of. Any opening in the body, they have a tube down there. They need to be washed constantly, and anything could go wrong at any time. And if you have a code, at least 6 of those nurses are on the code, running the code. So that was very scary. I remember we all only had 1 break for 12-hour shifts. And on top of that, some people stayed back for 16 hours just because they didn't have people show up. And most of these nurses are women with children. And it's hard. It's hard that for you to leave your patient to die because there's nobody else to take over from you. And the cycle continues. It was a very stressful shift, and most people called in sick the next day. So it's just a cycle.
So you are not just, you also do teach, you also do look into policy. Experiencing situations like that, what would have been your advice to maybe the hierarchy of the hospital or the government of Ontario, or somebody to do something, or some of us in the community? What would you have advised us to do, or what would have been the expectations?
Well, when it comes to people in the community, all they can do is write to their local MPPs, calling on the government to repeal Bill 124, right? Because that was the main reason nurses were quitting or quitting. Bill 124 is a wage suppression legislation put in place by the Ford government in 2018. So imagine, I just described to you how much the workload has increased, but the Ford government decided to cap nurses' wages, the power to bargain, despite the increase in workload, despite the nurses union calling on the government to repeal this bill. Nothing's been done. Instead, they're bringing in beds, furniture, because without nurses, we just have these furniture lying waste and they're not being put to use. I walk into an ICU and we have like 10 beds empty with thousands, of dollars worth equipment, and they're not in use because there are no nurses. Even the doctors are complaining that, okay, so I need to admit this patient, but we don't have a nurse. So the patient ends up staying in a merge or being transferred to somewhere else where they maybe have a nurse, And so yeah, my advice to community members, you have to write to your MPP. This is the time to vote. I don't tell people who to vote for, but I tell you, what do you want to see? Do you want to be in a healthcare system where you'll be in the hallway for days, or you don't have a nurse to look after you because nurses have quit? So what do you want to see? Or you want a system where no one pays attention to your disability. You cannot live on the minimum wage, which is barely a livable wage. What do you want to see? So look at the most disadvantaged person in the society and vote in their favor if you have a heart. When it comes to hospital administration, I honestly do believe they know what to do. Like, I'm not even gonna go into that. They know what to do. No one's gonna convince me that a hospital CEO doesn't know what nurses want. It's all over the news. Nurses are quitting because of Bill 124. poor working conditions, disrespect, lack of mental health support. So why don't you put that in place? So I work as an agency nurse, and I see how much hospitals invest in private agencies to come fill in for hospital staff. So why don't you just treat your staff well? Why don't you increase your pay so you don't have to pay another agency before they pay another nurse to come into your hospital? I do understand that we cannot completely eliminate those agencies because I don't know why. But the thing is, there more and more money is being given to private agencies, and nursing staff, they're not being incentivized to stay. So people are actually quitting to go work for private agencies, and somehow we're all contributing to the privatization of healthcare. But this is what the government wants, right? The hospital administration knows what to do. I'm not here to guide them on what to do. They know what to do, and unfortunately, it's not been done. Um,
Uh,
it's yeah.
Unfortunately, we also try to reach some of the hospital administrators to come and sit with us today, but nobody responded to us. Do you think it's a communication problem with the hierarchy in hospitals? Why can't they do the right thing?
Why can't leaders in power do the right thing? So many answers, right?
The hospital system is different. You know, we might say if you are building a bridge and it doesn't work, you come back the next day and put more blocks or put more concrete. It's not like that in the healthcare system.
But you know, people do benefit from chaos. Whether or not we like this system crumbling right now, there are people that are benefiting from the fact that nurses are quitting. There are people that are benefiting from the fact that the publicly funded taxpayer funded healthcare system is crumbling, because there are people that are getting richer because the healthcare system is crumbling. It is further been privatized, and a group of people have been, are benefiting from the chaos. So I see why some people will never want to advocate to make it public, or because they will not be impacted. They can afford private healthcare. So it's those of us who need public healthcare, and we know what it feels like. Or maybe, you can just take the United States, for example, and see what privatization of healthcare may look like for Canada, and how people will die because they cannot afford basic healthcare. We know the danger that could be, the danger in that, and we're advocating to make sure healthcare doesn't go private.
Okay. Yeah, there's a lot we can talk about the political side, but let's move a bit back. Let's talk more about Bill 124. I know everybody out there is blaming the conservative government for bringing Bill 124, but the liberal governments as well of Kathleen Wynne, they also were not helpful to improve they did some things, but we can't blame like the 24,000 shortage on the government that has been in power for 4 years. It must have been a long-term effect. So let's just focus on Bill 124 and talk about what the bill means to somebody like you and your colleagues, and what it means to some of us who will be patients.
So yes, just like you said, Ontario has always had the lowest RN to population ratio in all of Canada, even before the Ford government took power. Somehow, some governments think that if they need to fix something, they need to cut healthcare. They need to cut education, and they're always cutting healthcare. Unfortunately, it's been long coming, and Bill 124 doesn't help either. So Bill 124 is a bill that was implemented by Doug Ford in 2018. As soon as he got into office, he implemented this bill to cap nurses' wages and other public sector jobs for nurses, is that our wages are capped at 1% increase a year. What this means is that nurses cannot get more than 1% increase a year. So you could be a nurse and with 30 years experience, you're contributing to the growth of new nurses, your facility, but you can't get more than 1%. The workload has increased. Instead of 30 nurses on the unit, we have 8 nurses doing the work. You can't get more than 1%. Like, where else does this, where else do you see this? People get incentives for, even in marketing or whatever it is. And here we are, we're called heroes or whatnot in quotes, only to be slapped with a bill to say, listen, no matter what you do, even though there's a pandemic, you cannot bargain your pay. We cannot discuss your pay, and this is what it is. So people are feeling really insulted. Look at male-dominated professions, for example, a policeman who starts their profession the first year earns the same salary as a nurse with 30 years experience. And it just goes back to the patriarchy of a system and how we female-dominated professions are looked down upon. Nurses are expected to care, and because of that, we are not prioritized when it comes to pay equity, and that has to change. And a lot of my colleagues who know their worth are actually quitting as a result. Most people have had enough, and I cannot blame anybody for quitting right now. A week ago, I learned about 5 of my colleagues left. Some of them go to other areas of nursing, right? Not just quitting the profession altogether. Some have quit the profession altogether, but other people go to like administration, public health. With the vaccine clinics, people went there. They just left these specialty areas where you actually earn the same as any other area of nursing, right? And it's quite discouraging, really is. And I know people do say a nurse is a nurse is a nurse. I've got a lot of criticisms for saying a nurse is not is not just a nurse. Don't tell me that a family doctor provides the same services as a cardiologist or as a surgeon. Yes, they're all valuable, but some of them actually did more schooling and education, and because of that, their pay is different. So when it comes to nursing, a lot of nurses in specialty areas have done a lot more schooling. The workload is not the same. I know nursing is stressful altogether, but a nurse is not a nurse. And if nurses have had specialized training, they deserve to be incentivized based on their training and the amount of education they put in. But again, it's a female-dominated profession. Who cares? We're expected to pay to care. And so there's no incentive, and nurses are leaving. More people will leave.
So let's put this into perspective. So the bill 124 basically says if you are making $50,000 a year as a nurse, you can only increase that salary by 500. So the next year you get 50,500. If you are making 100,000, you get an additional $1,000. How much do you think your rents increased between last year and this year in Ontario? I don't know. There are people out there listening. If you can put how much you think your rents increase, I'll greatly appreciate that. Just put us the amount, because I'm just thinking about it. I've not done the calculations. I think Ontario, the inflation rate is about 6.5%.
It's ridiculous.
So
yeah.
Yeah, so that it's ridiculous. Like just thinking about it from an economic perspective, that increase is not even going to even it might not even cover your, I don't know what it cover.
Your gas.
It won't cover gas, definitely. I was thinking about even fruits
your
and
phone bill.
Anyway, so that's how bad the situation is. So yeah, as she said, I think what we can do is to call our MPs and MPPs and make our voices heard and try to support the nurses. We're almost halfway done. You can imagine how fast time flies on this podcast. So please, again, if you have any comment or questions, don't forget you can put them on the comment or raise your hand now, and I'll definitely call you. Let's move a bit fast. Let's talk about the codes in the hospital. We always hear about this code blue, code orange. What is the significance of this code system? And after that, I'll talk to, I know we had a code orange system, I think in Brampton. I would like us to talk about that, but just give us an overview about what this code system means and what they represent.
Oh yes, we do have emergency codes that alert hospital workers on what is happening, and based on the color, so they're actually color coded. Based on the colors, we actually respond accordingly. There are people trained and assigned to respond to certain codes in the hospital, and staff is expected to know what the codes mean. As a matter of fact, they're usually part of our identity badges, and they're usually at the back of our identification badge. So yes, the most common ones are code blue, which is a cardiac arrest. Whenever there's a code blue, whoever's the ICU nurses are assigned will run for the code. So in addition to having a patient, you give report, like, just let someone know quickly and you run to wherever the code is within the hospital, and the physicians, a physician or one or two will also attend, respiratory therapists, and nurses on the unit. So that's kind of it. So code blue is really common, unfortunately. We also have code white, which is more and more common these days. This for a violent person or hostage. So with the shortage of nurses and people getting really frustrated with the healthcare system, instead of taking their frustrations to the government or voting accordingly, they take their anger usually on nurses. So we've seen a lot of violence, patients getting very angry, and even family members getting sometimes aggressive towards nurses. But sometimes we do have code whites being called for patients, experiencing confusion, or when they become aggressive, just to have that support, extra support from security and also the code whites team, pretty much. And then we do have code yellow for missing person. If there's a missing patient, we respond by searching the rooms and all that to code yellow. And the less frequent ones are like code pink. I hate that one so much. I don't like the rest, but code pink is for neonatal cardiac arrest. So when a child is having a cardiac arrest, pediatric mostly. And also we have code red for fire, code brown if there's a spill, hazardous spill within the hospital. Code gray is when the systems are down, loss of utilities and all that. Code green if we have to evacuate, and also code orange, which is a mass casualty. Those are pretty much the code. I know there's a code black too, which is a bomb threat. Luckily, I haven't had to experience that.
Okay, yeah, I think as a community, I think it's good sometimes for us to just understand what some of those things mean, or just educate ourselves. Now, you predicted that there will be a code orange during. I think you said there will be some disaster or some hospital is going to collapse, and shortly during the peak of COVID, and shortly after that, I think there was some code orange in Brampton.
Yeah, Brampton.
How come you were able to already know that the system is about to collapse and no other person picked it up?
Well, so I belong to a group of critical a WhatsApp group. We have almost 300 nurses in that forum, and they're all agency nurses, meaning that they go to different hospitals, and we have insight as to what's happening in these hospitals. So prior to that code orange being called, people were already saying that, oh my gosh, I worked at Brampton Civic, there were no nurses, this is so unsafe, I'm not going back. So for an agency nurse to say I'm not going back, it's really bad. The assignment, the workload was very unsafe. I don't want to lose my license. I don't want a patient to die on me just because of the workload. So we already saw it coming because a lot of people talked about it. And unfortunately, as we know, Brampton is huge. I don't know what the population is, but they only have one hospital. And so you kind of see the discrimination is so systemic and so strategic. People don't realize, but once you start seeing these things, you cannot unsee them. So Brampton is huge. And here is just one hospital to cater for all the people in Brampton. And I know they have William Osler and all that, but and they have an older population too, which I don't know the numbers. So I knew it was definitely going to result in a code orange, which eventually did, and based on what other nurses were also talking about. But hospitals like to keep everything hush hush until it gets out of control. Compared to other neighborhoods, for example, Durham region has, oh my gosh, has one hospital every 15 kilometers, pretty much. If you go to Port Perry, there's a hospital. You go to Bowmanville, there's a hospital. Oshawa, there's a hospital. Ajax is a hospital. Like there's literally Whitby, there's a hospital. So many hospitals, and Durham is predominantly white. So you begin to see the systemic inequities. So Durham has so many hospitals within proximities, and then Brampton has one hospital for the entire very populated Brampton. And so yes.
So what happened when they gave the code? I'm just laughing because it's a really sad situation. And as somebody who had been a resident in Brampton, I completely understand what you're saying. I don't want to even go further to talk about the delays in the emergencies in that Brampton hospital and some of terrible experiences. I know women, Black women who've refused that they'll never give birth in that hospital. And they prefer to go maybe in Milton and other places. So why was that code orange? Like, explain it so that people who don't work in the healthcare understand what nurses have to go through because there was that code orange.
So a code orange is usually called when there's a mass casualty. The last time I heard a code orange called was in 2018. The Young Street disaster where someone drove into people and they had a call a code orange at Sunnybrook so that other non-emergencies or whatnots could be diverted to other hospitals, and just to maximize your staff efficiency, capacity, and all of that, and be able to manage the disaster. So when you have a code orange called because there's a shortage of nurses, that was just mind-blowing. I remember when I saw the message, I was like, oh my God, this is so scary, like literally scary. I could picture the patients. I could picture the population. They're racialized, and they're mostly Black and brown people in Brampton. And I'm like, why is a code orange being called in Brampton? We've failed people. People are going to die because of this. And if not, people are going to be disabled because of this. And it was just so devastating. And you just see how the systemic inequities contribute. So in terms of nurses, where are you going to find nurses because of a code orange? If there are no nurses before the code orange, you're not just going to automatically bring nurses in. Yes, during the code orange, a mass email goes out for people to come to work, but people will only go to work if they can, right? Like you're not gonna force
or if they are better paid.
Yeah, like you can't come pull me out of my house to come work under terrible conditions. And prior to that, I only went to work in Brampton, I think twice, and I said I was never going to go again because the conditions were so unsafe. And this was before COVID. So I could never imagine myself going during COVID. And when I heard about that code orange, I could only imagine the disaster. I don't know what happened there, but I know it was total chaos. And I cannot even imagine things that could have gone wrong, because you can't just manufacture nurses because you call the code orange.
Okay, so we have this hope or this belief that the whole COVID thing is over. But I was looking at the Public Health Ontario data, and it seems there's still like 9% rate of infection, and only 50% of the population got the third the booster shot or something like that. With the changes in policy, especially changes in the way testing are done, the way reporting is done, are we actually getting the real picture as of what is actually happening?
It is all political. Like we're not getting, like, without testing, how are you gonna track if people are not being tested? And unfortunately, people are not testing, people are no longer wearing their masks. And we're still seeing cases in the hospital. We're still seeing people come in with COVID-19. And despite being vaccinated, people who are immunocompromised actually do get really sick from COVID-19 and get disabled from it. Unfortunately, people are just moved on. People have moved on with their lives, business as usual. Things have gone back to normal for them. But we healthcare workers have to keep suffering and enduring and looking after COVID patients and wearing our masks for 12-hour shifts, 16-hour shifts, and being following other rules why people do whatever they want. Unfortunately, we don't see the actual numbers because we're not testing. And we can see that with all the outbreaks happening and in certain units, and also people, family members coming in and spreading COVID. Yeah, and we also see that in schools, right? A lot of school bus cancellations, classrooms going on, like it's just really hard to track right now.
What about the numbers in the ICU? Have there been a significant drop in numbers of COVID-19 patients in the ICU units?
Definitely, compared to like wave 1 or 2, the numbers have reduced, and thankfully, because people did get vaccinated, people eventually did wear their mask. Compared to wave 2, definitely the numbers are down, but we're still seeing cases. So the fact that we're still seeing cases means that COVID is not over. And the fact that people are actually not testing means that we're not tracking anything and we don't know who we're infecting or infecting us. And we will still see people get disabled from it. I would like to see, the pandemic being over, but it's far from over. It's not over.
2 weeks ago, we had we were discussing about mental health, and the experts were on the panel on the same platform. They were like the effects of COVID-19 we're going to start feeling it maybe in 2 or 3 years. And there was an issue that came up about nurses with burnout and so on. So on this podcast today, we are talking about the war is not yet over with COVID-19, and these are some of the things that we don't really see. Do you think there will be another crisis because we didn't manage or we were quick to say, oh, COVID is finished, and then nurses are just like, you know what? Because at the end of the day, nurses are humans. If somebody comes and has to be in the ICU or has to have care, and that person hasn't taken any vaccine and didn't want to wear masks, at some point, you as a human being will be like, why do I keep putting myself in danger when the people don't really value their lives? Are you getting any concerns? Do you get any concerns about this? What do nurses think about the scenarios like that?
These are really subjective, reactions. Yes, we do feel a collective moral distress when we see people that, could have avoided getting very sick, but took this so lightly, and it could be for many reasons, to be honest. And we're trained in our profession to be non-judgmental, even though we're human beings, and sometimes we're like, okay, this person had a chance to get the vaccine but did not. But we try to bracket our views and, think about other scenarios. So some people, for so many reasons, religious beliefs or whatnot. I've had patients who honestly eventually got vaccinated after we had a talk with them. It was mostly for religious beliefs. Misinformation played a huge role. I had a woman who really, she said, there's too much information out there. I don't know what to believe. You tell me. Did you get vaccinated? are your kids vaccinated? So we had a talk. The doctor talked with her, the pharmacist talked with her. She eventually got vaccinated. So it's easy to kind of blame people, but we always try to go back to say, okay, every behavior has a meaning. There are people that didn't get vaccinated. I know a lot of racialized people that honestly did not want to get vaccinated initially because of the lack of trust in the government, and again, and the fact that vaccines weren't made available to predominantly racialized communities early enough compared to other neighborhoods. And all of that just erodes trust and everything. So there's a whole lot of moral distress, yes, but we try to understand and try to see, just be present and work with them through their journey. It's sad when people are actually getting intubated and asking you, can I get the vaccine now? And it's like, it's too late. um but yeah, you feel it, you really do, as a human being. But how people react, I don't know, but for me, I really feel sad for them, and I wish things were different, but that's all you can do. And this is causing a lot of distress and burnout, and just, you're just tired. You wish people made better choices, but people will always make, the wrong choices sometimes.
Okay, let's talk about some of the personal things that affected some nurses during the COVID-19. We've talked about the stress of pay. We've not talked about mental health. We might not have time to talk about that. Another issue is if you are not well paid and you have COVID, were nurses being paid if they had to stay home due to COVID, or what was the situation?
So I had COVID myself last year, and I wasn't paid. First I had COVID isolated for 2 weeks without pay. And then I had to isolate again because I was exposed. So, and there was no pay. So it was about 28 days of no pay. Nurses weren't paid. You only get paid if you're full time. And yeah, that's the nature of the job. We're just heroes in words, but the policies don't reflect any of that praise.
So
Nurses. Mhm.
what would have stopped a nurse who say who needs to feed the family, needs to pay her bill, and she finds out that she has COVID? What would stop such a nurse from coming back to the hospital?
Nothing. Just your values, whatever it is. People did go to work sick. And unfortunately, it is what it is, right? And that is exactly why there's been advocates advocating for paid sick days, 10 permanent paid sick days paid for by the employer, but we still don't have that.
Is this not going to compound the problem we already have with shortage of nurses? Like, if anybody powers through all this and then sits back and say, okay, let me relax and figure out what I've gone through, without not just to make the person just say, you know what, this career is not for me, or I've contributed my own portion to humanity, it's time for me to look after myself. It's
So
funny, but that's true. Like,
yeah.
nurses, as you say, they were called heroes, and what was the fancy word that was used? You people used to cut the line when we were going to Costco, and you had preferences to do shopping with no money. And then suddenly we are here in a crisis. And I only see these, especially in Ontario, we'll have a shortage. Are we seeing more people getting into the nursing field right now? Has there been a huge amount of enrollment in the schools that you teach?
You know what? Actually, um, there's been, I would say, they try to increase funding for enrollment to encourage people to apply to the nursing profession, but I don't know if people are,
We don't have
if
the numbers.
enrollment has dropped or not. And yeah, and enrollment actually doesn't mean that people are going to graduate. And people graduating also doesn't even mean that they're going to stay in the profession. A lot of nurses quit the first year of practice. That's the high of people quitting the profession the first year because the stress is so intense and people are just done. So I don't know really.
So what would you advise your future students? Those
Oh
of
my
them
goodness.
listening right now, what would you tell them to do?
This is a question I'm actually avoiding. I teach nursing and I tell people it is a very rewarding profession. You just have to, it's hard. It is hard. And the pandemic has actually made it harder for me to tell people to choose nursing. And when people choose nursing, I say, do what you can, advocate for better pay, advocate for better working conditions. If you know that the profession is burning you down, maybe it's time to rethink. You shouldn't be in a profession that will make you lose your mind completely and lose yourself. So maybe that'll be a point to have a rethink.
So if we have to project ourselves 5-10 years from today, what is your most optimistic output when it comes to nursing in Ontario?
Unfortunately, I'm none. I'm usually very optimistic, but the future of nursing right now is so bleak. People do not understand the impact of the shortage we have right now. We have experienced nurses leaving the profession, and because of that, new grad nurses don't have the support and are leaving as well. So we're going to have a very deep vacuum to fill. And I think that we need innovative strategies to be able to retain nurses if we must have a healthcare system at some point, because we know that nurses make the majority of the healthcare system. And without innovation on how to retain nurses and better pay, the nursing profession is really bleak, to say the least, and I'm not optimistic at all. It is very bad. I cannot describe how dire it is. It is devastating to be in the profession and just see it decline so fast. And it may not be able to recover quickly unless there are innovative measures put in place. And this includes, at some point, there may be free tuition for nursing if people will join the profession. And there should be better pay if people will remain, and better working conditions and support. For now, I don't see a promising future for nursing if things are not put in place fast.
Well, I was hoping you would give me some hope. But you sound like the nurse of doom.
Well, I'm keeping it real.
Well, yeah, that's the reality, unfortunately. We have a hand up. Let me call Lady Abba. Please unmute yourself and let us know what comments you want to make, or if it's a question.
Wow. It's wow. You've really said a lot, but thank you for what you do, whether it's in the community or as a nurse or as a teacher. It is really highly appreciated. But you look good, right? And when you say nothing is the way it is, and people look at you, they're gonna say, okay, maybe she doesn't want us to look as good as she does. And that's just an aside. You talked about leadership. Leadership, and I understand that certain government did certain things, but let's take Brampton, for instance. They do have a mayor. They have MPPs, they have MPs. Why is anybody not taking any of this on in terms of, and I mentioned Brampton because I remember when they built that big hospital and they were like, oh, this is just going to be more than enough for Brampton. But if they feel it's not enough, it's not, I don't think it's up to the premier alone. And I'm just playing the devil's advocate here, and I have a lot of things I want to, so let me just reel it off and then you'll take it on. I know you said Brampton has one hospital, but you mentioned Durham region. But remember, it's a region. Each city, each town has their own hospital. That's the way it is mapped out, kind of. Maybe all these mega cities, they really need to kind of put some strategies in place. And if the people are not talking, if the leadership are not talking, how is that even going to pan out? Capping the income, that is, oh my goodness, how are you guys coping? Inflation is about 6.7 right now, and all you get is 1%. I work from home. I've been working from home now for about 18 months, and I go out once in a while, and when I fill my car, I'm like, oh my God, how are people doing this? I go to the grocery store and I buy things and I can't even see what I bought, and money is going. I really don't know how you guys are doing it. But the question I have, again, I want to play devil's advocate here. When that income was capped for nurses, was it also capped for doctors or for any other jobs, in the province, just because they what's it called now? What is it now? It just disappeared from my brain. Feels there's no resources to do that, or was it just targeted at nurses? Does agency pay more than full-time nurses? And what would be the benefit for a full-time, for somebody to stay as a full-time as opposed to being an agency nurse? And I know you've said a lot, but if there were 3 things you want that you feel would change the tide of everything that you've seen based on your experience and everything, what would those 3 things be? Because now you're empowering me to go back and talk to some people, because I will. Because if we don't speak up, nothing is going to change. And we all know that when 2 elephants fight, it's the grass that suffers. As much as we stand out because of our exoticness, most of the time we're unseen. So there you go. You have it. All of it.
But let me answer some of your questions, Lady Abba. Now I'm the moderator here and should not be answering some of these questions. I think the population of Brampton is just over 650. Let's say between 650 700. The population of Durham is under 750.
All of it, right?
The whole of Durham, yes. So we are talking here of somebody 750,000 people having one hospital. Let's say they're equal even, and another 750 were having 3 or 4 hospitals. So
5. Okay. So there needs to be some consideration for mega cities.
Yeah.
Okay.
Yeah, I think also when they opened that Brampton hospital, I think it was a huge error to close the old hospital, because they basically transferred from the older hospital, which was small. And I think they've gone back. I'm not very sure about this, and somebody who is there might correct me. I think they've gone back and started using that where they had the former hospital. Okay. Go ahead.
All right, I'm trying to remember all the questions. Thank you so much for the compliment. I love to look good no matter what. And also the fact that I prioritize self-care I think is important. I don't want my job to wear me out to the point that I lose myself, and I definitely do. And this is one of the perks of working as an agency nurse. So I'm going to start from the last question that I remember freshly, which is, does agency pay more than staff nurses? So in a way, it's yes or no. And this is a very tricky part, because agency nurses get a lot of discrimination and attacks because of the assumably higher pay. And I like to explain this to people because it's so important. So being an agency nurse comes with a lot of risk, personal risk, and all that. In addition to all the risk of being a nurse right now that I told you, agency nurses bear additional burden. There's no team support, nothing. You go into different hospitals, learning about different equipments, different teams members and everything every single time. So you need to watch your back. People are ready to throw you under the bus anytime. And majority of agency nurses are racialized women. Few men, majority of Blacks, as a matter of fact. So you can imagine the discrimination. I've gone into hospitals where I've been there for years and they call me agency nurse. And I'm like, I have a name. I don't call you Brampton Civic, neither do I call you, you know, Trillium Health. You have a name. So, and the fact that we're painted as whatever is all part of the racism. And are we paid more than staff nurses? It looks like we are. So I tell people, they give you your future in advance. So you have no pension, you have no benefits. If you get an injury, you have no pay, you have nothing, zero. In addition to that, heavier workloads. So nursing is really hard right now, correct? But being an agency nurse, you go into different hospitals to offload the burden. You're constantly having heavier assignments. And I say this any day, anytime. There's no support. Very few people will support you because it's just, you find good people sometimes. And so yes, the pay looks like it's more, but it's actually less in the long run. Because when you're hired by a hospital, when you're full-time, you get your pension, you get your sick days, you get your benefits, you get all of that. But as an agency nurse, you have none of that. And to help you manage those risks, you get a little extra. So it looks like you're getting more cash flow, but there's no future plan. So that's kind of how it works.
I'm trying to rush because of the time. We have a professor in statistics. His hand is up. I would like to call him in. Maybe he's going to give us more numbers. Professor Fortune, please unmute yourself and let us know if you have a comment or a question.
Okay. Yeah, no, thank you. Is it Birgit for a wonderful presentation? I've enjoyed it.
Okay.
Interestingly, I spent a lot of time in Botswana in Southern Africa, and I did quite a bit of research involving nursing working environment. We probably have about 6 publications in that. If you look at Fortune and FACO, you'll find that we have quite a bit of publication from stress among nurses, from productivity among nurses, from job satisfaction among nurses, and so on. And it was actually motivated by complaints about nurses when we started working in that area. Nursing in the hospital, nursing in community, and nursing also saying more or less exactly what you've been saying. And pay always came up. But what surprised us in our research was that the most important things that consistently came up in all the work we did were not actually satisfaction with salary or pay, they were the working conditions. So consistently, working conditions, relationship with supervisors, relationship with management style, even having opportunity to go on holidays. Consistently, almost every time we did a survey, came up and found that when those were satisfied, salary were not really as important. Of course, because you are working in an agency, I don't know how much that plays, but exactly all the points you raised were the same things that we're finding there. And unlike Cameroon, where I come from, where you grew up and nurses were men and women, in Botswana, nurses were women. We actually had a very interesting situation where we did a paper on midwifery, and we sent for a journal. The journal said, there's no midwife in your study, so we don't think that you are qualified to talk on midwifery. And we try now to say, okay, look, we've done the research, but we can get a midwife. And the only midwife we saw surprisingly was a guy, but he was working in the university and he did midwifery training, but he never went to work in the hospital because there were no concept of a man being a midwife. But he was trained as a midwife and then went to teach in the university. But anyway, what I'm saying is that the situation you are raising is very similar. But we found that it was really the working conditions consistently, relationship with supervisor, management style, facilities as well, not just available facilities that they needed, and even support. So I don't know to what extent salaries play as big a role as we see, vis-a-vis the relationship within the hospital itself.
Yes, thank you so much for your contribution. Yeah. So right now, in terms of, I'm talking about specifically about Ontario nurses, salary is a big one because of Bill 124 and not being able to bargain pay. As a matter of fact, a lot of nurses went to Queen's Park. Last year, I was part of them. We rallied for Bill 124 to be repealed. So salary is huge. And of course, working conditions and all that. And the reason why the working conditions are so bad, because nurses are quitting because of the salary, and then leaving very few nurses at the bedside, and the working conditions are even worse. And then no mental health support. And of course, relationship with management and all that plays a huge role as well. But I think right now, given the cost of living, which has gone up, inflation and everything, salary is like number one.
Okay.
3 things that I feel to be changed. Definitely a repeal of Bill 124. Nurses should be able to bargain their pay. Provision of mental health support. All nurses should qualify for mental health support, whether or not you're full-time, part-time, casual, you should be able to qualify. And innovative strategy to retain nurses in the profession. And I also really want to add that incentivizing specialty areas in nursing should be a priority at some point.
I would also want to add that I think it's important for nurses to be given some time off, paid time off, irrespective of within a year. It has to be mandatory that you take maybe 4 weeks off just to go and relax and come back. So,
and work flexibility. Flexibility is key.
Yes.
We don't have that.
If anybody has any comments, please drop them in. You can check on the chat. I've put how you can reach out to Birgit. We also have put a link to our YouTube channel as well. Please do follow her on her Twitter page. It's very important that we support her. Before we close, what is the one thing that you think those listening and those who will be watching should take out from this discussion?
If there's one thing you should take out today, is basically to prioritize your vote and make sure your vote counts. I know some people may not have voted before, but please, if there's something you should do, read the platforms of the political leaders and vote wisely. Please vote. If you've never voted and you can, please vote. That is your right, and you can change things with your vote.
Thank you, Birgit, for being with us today. I think it's been a very educative discussion. It's opened a lot of our eyes and our minds, and hopefully we'll continue having this discussion. I know you've taken part in the other TV discussions. I believe this is the one that has taken the most time, and you've really explained yourself, and we really, really do appreciate that. We are going to definitely try to push some of these things that you've said out in the community. And please don't hesitate to reach back to us if you think you need the community support. I think one of the things that we've also failed our nurses is that the community has not been there for you people. There are a lot of things that I believe we can do, like even doing phone calls just to make sure you're okay, supporting some of your causes, join the nurses when they go on the protest, on the strike. I think those are things that we in the community need to start doing more. Again, thank you so much. Those of you who've been listening, if you want, you can unmute yourself, or you can turn on your camera and tell Birgit thank you. And we are going to be rounding up process. In 2 weeks, we are going to have another discussion, most likely on a book. And we are going to send out our flyers, and I wish to see all of you. Thank you. Thank you for listening, everybody.
Thank you very much for having me. Thank you so much for listening. Thank you.
Take care.
Take care.
Happy week. Now have a nice weekend, everybody, and bye-bye.
You as well. Thank you.
Bye.